Hi, this is Minister Joannides, Chief Medical Director at Optimum Re, and this is the Optimum Academy, PrEP and HIV 101. This is video number 5, HIV positive co-infections. So let's get started. So one of the co-infections we're concerned about in applicants who are HIV positive is TB, Mycobacterium tuberculosis. TB and HIV positive applicants is a worrisome feature. So how do you check for current latent tuberculosis or active TB disease? So do they have an infection that hasn't spread, or do they have active TB disease that has spread in the lungs or to other areas of the body? So latent infection versus active disease. And that's often used as well before starting biologic medications, just as people who have HIV disease could be at risk as well. So what's the difference between latent infection and active disease? So to detect latent infection, which is an infection in the body but no active disease, a skin test or what's called an IgRA test is done. If those are positive, the person may have a latent infection. However, they're checked for disease by getting a sputum culture and a chest x-ray. If the sputum culture and chest x-ray are negative, they just have latent disease. So an infection in the lung, but no active disease. Active disease would be a positive skin test, an IgRA test, which we'll discuss in a minute, but also either a positive sputum culture or evidence on a chest x-ray that there's active pulmonary disease. So a skin test to the left shows up as a raised red or erythematous area. It feels like a mosquito bite. In other words, it's raised. And you only measure the raised area. You don't measure the red area, which may be larger. So people that have a positive skin test or positive PPD, it would look something like that, and it's measured, and if it's beyond a certain dimension, then it's considered positive and the person has latent infection. They would be checked with the sputum culture and chest x-ray to make sure they don't have active disease. A chest x-ray that would show either a cavity or infiltrate would be considered active pulmonary tuberculosis. TB can also spread to other areas of the body. So people that have active pulmonary TB might be checked for TB in other areas of the body as well. So this kind of demonstrates what the difference is between dormant latent infection and active disease. You can see to the left, everyone looks preoccupied with their phones, but they're generally in an orderly fashion, whereas on the right, active disease is chaos, and the body is at risk for further spread. So what's this IgRA that I mentioned, which is now being done actually more frequently than skin testing? IgRA stands for interferon gamma release assays. A lot of fancy words to measure the immune system reaction to tuberculosis in the body. The one we see most often in medical records is called the quantiferon TB Gold Plus blood test. So this is a blood test. It can be abbreviated QFT positive. And a positive test means that the person has been infected with TB bacteria. So you need to determine if the person has latent TB or TB disease with sputum culture or chest x-ray. A negative IgRA means that the person's blood did not react to the test and that latent TB infection or TB disease is not likely. The reason this is being done more frequently than skin tests is with a skin test, the person has to return in 48 to 72 hours to check and see the size of the bump that may be present where the skin test was applied. Whereas with the IGRA, the person has blood drawn on their initial visit, and then the lab runs the test, so the person doesn't have to return. So this quantiferon TB gold testing, so here's what the testing profile looks like when a test has been performed. It's a little complicated. We're getting in the weeds a little bit here, but this is what actually occurs, and this is what we might see. So the quantiferon TB Gold Plus test is determined by subtracting the nil value from either the TB1 or TB2 number. The mitogen serves as the control for the test. So a positive result is when the TB1 minus the nil amount and or the TB2 minus the nil amount are greater than 0.35. Sounds complicated, but we'll go through the test here and demonstrate how this actually applies. So you can see in the boxes in this particular test, the quantiferon in the first line in black, quantiferon Gold Plus test was performed and reported as positive, and the reference range should be negative. So the TB1 tube had a 0.59 value. To be negative, it should be less than 0.35. The TB2 tube had a 1.09 value. The negative value is less than 0.35. The nil value means this is the standard, which should be basically 0, and this is 0.08, so we're close to 0. So what you do is you subtract that value from the TB1 tube value and the TB2 tube value. The quantiferon mitogen value is the standard of a positive, and that's greater than 10, so a large number. So this is how the test result should look. The TB1 and TB2 values, the nil value should be close to 0 and is subtracted from those two numbers, and the mitogen should be greater than 10. In this case, with TB1 is 0.59 minus 0.8 gives you 0.51, so that's greater than 0.35, so that's positive. TB2 tube is 1.09 minus the nil value of 0.08 is 1.01, so that's greater than 0.35, so that's positive. So this person has a positive quantiferon TB Gold Plus test. And look for these in the APS, and you'll be able to assess the results yourself. If the nil value and the mitogen value are not similar to this result here, the test may have been done incorrectly. So it's good to keep an eye out for some slip up in the lab if the values for these two standards is not correct. So another adverse factor which can cause problems in HIV positive applicants is smoking. It's a dangerous health threat for people living with HIV disease and causes a shorter lifespan. So in addition to a smoking rating, we actually are more concerned in HIV positive applicants and may add an additional rating in addition to the usual tobacco rating because of the downside risks in HIV disease. And approximately 50% of HIV positive applicants are found to be tobacco positive. Fortunately for applicants that come through for life insurance, the number is much smaller than that. So HIV positive applicants that we consider, often the HIV is undetectable and the CD4 count is high, which is favorable. So the HIV is being effectively treated. However, the applicant may have other medical impairments that call for a rating or decline. Avoid writing any underwriting notes concerning lifestyle choices in the record, and smoking tobacco has a worse outcome in HIV positive applicants. We check for STDs or other infections, and syphilis titers can be particularly tricky to consider, especially when you get low levels of titers and you're not sure if this is a new infection or a residual infection that was treated effectively. So there's a new algorithm for testing for syphilis, which is often evaluated in applicants that are positive for HIV. It's called the reverse algorithm for syphilis testing, and it uses an Alexis syphilis ECLIA test, which is called a treponemal test, because the syphilis bug itself is a treponeme. So this is a treponemal test. If it's positive, it's followed by a non-treponemal test, which you have seen in APSs called an RPR or VDRL. More often now we see RPR. So what has been reversed here is, in the past, RPR was done first, and then another test that was a treponemal test would follow it. Now the algorithm has been reversed, and the treponemal test is done first, and the non-treponemal test is done later. If the two tests are discordant, in other words, they're not both positive or not both negative, a TPPA test is done, which stands for treponemal pallidum particle agglutination test. So what I see in APSs at this date is many physicians are still using the old RPR first, then a treponemal test, and now this new algorithm recommends the reverse. So in the old algorithm, we had the problem of sero-fast RPR levels as a titer of 1 to 8. And it's difficult to tell if it's a new infection with a rising titer that needs to be treated with penicillin, or an old treated infection with a baseline residual titer but no active disease and the person's been effectively treated. So this new reverse algorithm uses this system, which is automated, called an Alexis automated treponemal test system. It's a new immunoassay for the qualitative detection of antibodies against Treponema pallidum, the bacterium that causes syphilis. If Alexis is positive, then go to the RPR test. And if discordant, if they don't agree, you go to the TPPA test. But not everyone has adopted this, but this is one of the recommended ways to evaluate for syphilis, which is often required in people that are HIV positive. And here's an example at the top of the old school type STD testing, which I still see in APSs, where only the RPR was done and no treponemal test was performed. And then usually other STD testing is done as well, like chlamydia or gonorrhea. I've highlighted those in yellow. So this Alexis treponemal test system has a high sensitivity and specificity. It outperforms the traditional algorithm of doing an RPR first. It's automated, and the result is quickly obtained in as little as 18 minutes. And so this is just a comparison of the, the two algorithms. The traditional way was RPR first, a treponemal test later, but now the reverse sequence is being recommended with the Alexis system, doing the treponemal, treponemal test automated first, and then the non-treponemal RPR test being done. So the equipment that's being used is from a Roche called Cobus, and it facilitates this electronic checking of the treponemal test first, and then non-treponemal tests can be done following that. And this is the sequence. It just shows you the difference between the traditional algorithm and the reverse sequence algorithm. And this just describes about syphilis, the difference between primary, secondary, latent, and tertiary. So syphilis is a complicated disease. It was thought to be on the wane. However, it has actually increased. And so that's why evaluating for syphilis is especially important in HIV positive applicants, and all pregnant women receive testing for syphilis as well, since syphilis could affect the baby after it's born. So what is this RPR and the VDRL tests? These are the non-treponemal tests, and when they're done, in order to get a good sense of what the titers really mean, they should be done at the same lab, and if the RPR test is done, then a follow-up RPR test should be done, rather than switching back and forth between RPR and VDRL, since the titers are not interchangeable. RPR titers are frequently higher than VDRL titers, and some people remain serofast at a low RPR titer of 1 to 8, even after effective treatment. So you can refer to your medical director if you get confusing results. The non-treponemal tests for syphilis are this RPR and VDRL, and they can be positive in diseases or conditions other than syphilis. So that's why algorithms are used to make sure that the person indeed has syphilis and not some other disease just with a false positive RPR reading. And then a fourfold change in titer is significant. So if a person goes from 1 to 16, from a 1 to 4, or goes from 1 to 8 to 1 to 32, that's an important test result to recognize, and further testing would be required. This TPPA test, it detects antibodies against Treponema pallidum. It's used only as a confirmatory test if the initial test in this new algorithm is positive, but the RPR or non-treponemal test is negative. And it detects antibodies which persist for life. So if it's positive, it indicates either previously treated syphilis, early syphilis before the RPR becomes positive, which is one of its unique features that's very helpful, or late or latent syphilis in untreated individuals. A negative TPPA suggests the initial treponemal screening test was likely a false positive. So that's why this confirmatory test is very useful. Now I wanted to wrap up with our Optimum Life manual HIV rating. And you'll notice that before the ratings, we actually have any indication of unfavorable characteristics, including associated disease, conditions, AIDS-defining illnesses, or the like, would indicate an RNA, or decline for that particular case, or any history of documented CD4 counts that were less than 200 would be referred to an MD to evaluate. Any complex questions about the HIV history, maybe co-diseases that were either treated in the past or questionably present now, should be referred to an MD. And then current tobacco user, we said, was a negative factor. And then what we did is we have this chart here. We don't accept applicants who are less than 30 years old, and then we have brackets for 30 to 34, 35 to 39, etc. And then depending on the duration of complete viral suppression with CD4 count above 350, is it 0 to 1 years, 1 to 4 years, or over 4 years? And in this particular case, which I included, you can see that the diagnosis codes, the person is HIV positive. However, in bullet number 2, they have hepatitis B as well. So they're not only positive for HIV, but also positive for hepatitis B. That would be a negative. Their serum creatinine was also raised. And one of the negative features of the medications which were used in the past, like Truvada, is they can affect renal function. So that may be due to a disease process or due to medication which has been used in the past. And then you can see that this particular person is being treated with Biktarvy, which is circled in red, what the CD4 count was at 454, and that the HIV RNA PCR test was UD or undetectable, which is great. So this person has the unfavorable factors of combination of HIV positive and hepatitis B with a raised serum creatinine, but has the benefit of effective treatment with a high CD4 count and undetectable HIV virus. Other tests that were done to make sure the person is not at other risks. The hepatitis C was done, which was non-reactive. You can see that the syphilis, this had the old school type testing, was an RPR, and that the screen was non-reactive. They also had a TB quantiferon gold test, and you can see that circled in black. It was negative. You can see that this person had no evidence of prior anogenital HPV disease, and then the particular genotype of the HIV virus was also provided in the thick green circle there. So whoever's treating this particular applicant certainly is on top of checking for co-diseases or co-infections that might be present, and effectively treating the HIV as well as those other diseases. So in summary, and what we would recommend is all applications on HIV positive applicants are reviewed by the Optimum underwriting team and medical directors. All HIV positive cases are treated with the utmost confidentiality and privacy, and we do not send unencrypted emails regarding cases identified as HIV positive. We confine underwriting notes and comments to medical impairments and avoid any comments about lifestyle. Insurance companies are at risk due to the need for confidentiality by all the other people participating in the application process, including paramedics, admin staff, agents, and all communications with applicants, insureds, etc. In the U.S., California auditors are likely to be looking for any infractions regarding HIV positive applications after January 1, 2023. And we're available for any questions regarding HIV applicants or our manual guidelines, especially on difficult cases. That completes our series in the Optimum Academy on PrEP and HIV disease.